to accelerate this. Now we'll move on to the last debate. Can we manage patients transnationally? And I'm going to ask Tekkerl Anderson, Thomas Berglund, Sophie Boissard, Nathalie Salle to come up to the podium, and the debate will be chaired by Philippe de Normandie. So we have a quick video first. For a long time, the words tourism and medicine did not necessarily go together. Then Uncle John organized a little weekend in Budapest and used the opportunity to have a dental implant done. Then there was Jane, the neighbor, who came back from Poland without her glasses. She used her trip to have her short-sightedness corrected. Currently, medical nomadism mostly concerns small operations for patients looking to pay a lower price for healthcare. In the future, however, who wouldn't be tempted to seek the best European hospital for a kidney transplant, a hip replacement, or even cancer treatment, or any other medical problems? There are many. We might even see the emergence of European centers of excellence for each discipline. We don't know. Yet, although crossing borders for healthcare is likely to become more and more commonplace, the European Union seems to be finding it difficult to get to grips with the coming upheaval. Who's going to pay if there's an accident or medical error? And how can continuous healthcare monitoring be guaranteed once the patient has returned to their home country? And that's without even considering the issue of reimbursement rates, which is a thorny topic. France is a prime example of a country behind the times when it comes to medical tourism. Although it has an excellent reputation for healthcare, France seems to be ignoring this considerable growth sector with its potential for profit. Thus, in 2014, while Germany totaled 2 billion euros from foreign-paying patients, France only scored 120 million. Tourism is like any other tourism, and medical tourists are seen as tourists, and the attractiveness of the country also depends on how good it is at hospitality. Hello, everyone. A very interesting topic. Is it a myth or a reality? Are we already seeing these transnational patients across Europe? So, Tekkerl Anderson, you're the president of a European organization. I visited your site. You doing a lot in Europe in your association, and I imagine all the documents that you've made available potentially to the patients with rare diseases, how they can get around Europe. You must get a lot of requests for these patients going from one center to another. Is this a reality, or is it more complicated than that? I can only talk about rare diseases, but for rare diseases, the 2011 directive really guides us. The directive made it possible to create European centers for rare diseases, 24 networks. And this is a first step towards a European treatment of rare diseases, and that's very important for us. The directive, as we've discussed, underscored the importance of cooperation on access to drugs. In fact, we need to reduce the inequalities that exist between the different countries. Patients are suffering from tardy access to certain drugs. And for that, this directive is something that we're very happy about. But at the same time, for rare diseases, the progress that we've made is minimum. The percentage of rare diseases when we look at the total number of patients that can benefit from transnational care, it's minimum. It's something like 2%. It's very low, the patients that are benefiting from this. If we read the directive, the aim of the directive would be to, as a priority, deal with rare diseases and care for these patients. Yes, that's a bit of a Trojan horse of Europe with the patients traveling around Europe. The reference center is in Europe. You have important centers. With Capio, you've developed innovative treatments, rapid recovery after surgery, RAC. Does that correspond to a volume of activity? Do you have an organization to try to ensure that in Germany, France, Sweden, where you're set up, you can, based on your competencies, attract patients that come from across Europe?
It's a private company, but that is listed on the stock exchange. But we are not doing private healthcare in the meaning that people come with their own money and pay us for serving them. So we serve the governments, local or central governments. In France, it's the central government that provides healthcare. So we are not primarily working with the very rare cases where I agree with what you said. But I think that the main road to go is to bring good medicine to where people actually live or nearby. I mean, the idea that you should fly somewhere and have a serious intervention and then stay there for a few days and then fly back, that's basically for the rich, but not for the smart.
Donc c'est très faible dans vos activités.
So what do we do? I guess I don't need to answer the question there. Yes, we have a few international patients. I would say it's more international within the Scandinavian area because there we happen to understand each other in our different languages because they are fairly close to each other. There is much less of patients traveling the longer distances. Do we move doctors and nurses in between countries? Well, very little, but to some extent, yes. But again, we think there are better, more efficient ways of exchanging know-how, and we think we have demonstrated that between the Nordics and France, for example, the last 5 years.
Très bien, merci.
Very well. Thank you. Mrs. Boissard, you have activities and SSR linked to your MCO activities. So this concerns the elderly people, the retired people. So this has to develop this activity, or is it also very marginal? I would agree with Mr. Berglund, including for the type of patients that Corian works with. It's France, Germany, Belgium, Italy, so Western Europe, 250,000 people treated each year with many multi-pathologies over 80 years of age with support for at least from 1 month to several years. And like for primary care, it's proximity that counts and the financial aspects, because we're not a dedicated operator to deal with private rich patients. We're really a grassroots treatment. So I looked in my 250,000 patients and I wanted to see how many people met this image. It's very low. We have some trans-border people, some people in France who will decide to go to to French-speaking Belgium because they'll get treatment in the same language, and that's important. And there are problems for place and availability in France, and also problems with financing. But today, very clearly, the topic for me is very local, and I see trans-regional aspects. Patients coming from one region to another, but very few transnational or inter-European patients. Is there an impact because retired people are moving to take their retirement in another country? You're not seeing an impact on geriatric treatment? Well, I see two things. One, very clearly, we have valid people, healthy people that have no harbors, and when they go to move to sunny countries where the standard of living is lower, so it doesn't correspond to the zones that we're active, which are really in countries with the same standard of living as the other Western European countries. And then there's a second case where I think of rare diseases. would be relative to have European subsidiaries. That would be for recovery of people after a stroke or a neurological incident, where it would be nice to be in the sunny with favorable weather conditions, and that can accelerate the patient's recovery. So we're seeing medical centers in the south of France, in Spain and Italy, and then we're confronted with other types of problems. Who pays for it? Will the insurance companies decide that they will pay for it, and what medical teams will be deployed in order to be able to care for people in their own tongue? So Professor Salle, Bordeaux is an important medical center for geriatrics close to Spain. You're at the management board of the university hospital. With the colleagues, is this a topic that you discuss? We need to be attractive for patients from European countries. Is that a topic that you address? So I'm the geriatric specialist around the table. I deal with elderly patients. So they're sick people who are losing their autonomy. And I'm lucky to live in a region where the patient pathway actually means something. We're surrounded by the management of our hospital that really believes in the project, and the region also believes in the project. So we have local recruitment. We will be treating patients who live near to the hospital, and we are not looking for patients who live farther away in other regions or in other countries. We need to have this organization side. The GP is very present in the treatment. We couldn't do that in a transnational way. The nurses, and all of the other healthcare staff that work with the elderly patient are important in the patient's health pathway. However, when you talk about the management board, we've had some discussions around sharing our doctors' skills rather than transferring patients to other countries. In countries where they need French expertise in geriatrics, there are other examples in other specialties, though, then why not? Yes, we have practitioners. When we see them work, they're often called upon by other doctors in other countries, European or African countries, and their expertise is requested. We also have specialists like myself who have patients that travel, who will go visit their grandchildren in another country. And because they have a chronic disease, they might need care while they're there. And in that case, and I'm talking about telemedicine there, I can track the patient remotely, but those are sporadic cases. But if I listen to you, we come back to the film. There's a bit of tourism, medical tourism, dental tourism for eye care, but it's quite limited. And when we listen to you, the obstacle is not an administrative obstacle, even if they exist. There are more obstacles in terms of when you're a patient, you need a whole environment around you. And tracking a pathology remotely is difficult. If you identify obstacles, where would they be? An administrative side, or the fact that I want to be close to my family or close to my GP? I find it hard to identify with the term tourism when we're talking about rare diseases. The patients are in desperate situations, and we have the need for a diagnosis and care that can be difficult to find. Unfortunately, I feel that if we succeed in finding an expert in a distant country outside of Europe, there are barriers and problems in convincing the health authorities. There can be very long procedures involved. Well, we sometimes feel that the application of the rules, the application of the 2011 directive isn't understood in the same way in all countries. When I prepared this, I was struck by the number of administrative procedures that are required, the authorizations between countries. So it's extremely complex for the patients to manage. Yes, absolutely. And the directive has planned for the creation of contact points in all of the countries now. But the information that we receive can be at very different levels in the different countries.
Be a bit provocative then, and the reason to go to another country to make a fairly simple operation or something, there is no medical reason for that. There's no medical logics. It's a lot of extra cost and a lot of exposure to traveling when you maybe should do a bit less traveling. It's the rationale is, of course, it's nice to come to another country, but that is a tourist decision. It's not a medical decision. And that seems to organize itself. I think we should rather focus on to do the journey for the patient shorter. Who wants to be sick 10 days if you can be sick for 5? That should be our focus.
Le terme tourisme.
The term tourism shocks you, and it shocked me too. But I did find in a very long report, a European report published in 2017, where they're talking about health tourism. And in health tourism, they identify medical tourism, well-being tourism, and spa tourism. They've encompassed all of this in this general term of health tourism. I encourage you to read this very interesting report. You can learn a lot. And so what about the other obstacles? The families, the support team, is that important for the activities that you're undertaking in your healthcare?
So there are two factors here. The first is the financial management of all that. How do you cover it financially in healthcare? That's covered by 50%, 80%, or 100%. The question of who is paying is important, and then we've already talked about the rules. If we can't have the same healthcare where we live, then that is a problem. So, and then there is expertise required for very rare diseases, people who travel for that because of the necessity to do so. And then there are other cases where we're looking for close-by healthcare where we are. And the second, this is what Professor Sal was saying, got the fact that for chronic diseases, which is the case of people that we're talking about, we're part of an ecosystem. And we can go to a rehabilitation center, we can go to a long-stay center. And these networks, and we'll come back to the debate from previous roundtables, because of training, because of the way these ecosystems work, these networks are above all national and especially local. Isn't there also a problem when it comes to practices? We can see the obstacles, but after listening to the other panel discussions, especially the one just before this one, there can be real problems with respect to practices that are different. So you can monitor chronic diseases, but what happens when people are moving around? And this brings me to the question, Professor. In your conferences, especially your European conferences, is there a lot of thinking about these practices, these nomadic practices, and the patient and the services we are offering patients? Can we build a Europe without wondering about the ability to have practices that are more homogeneous between our countries? Now, we're very lucky in geriatrics to have a lot of coherence in the way we manage our elderly people in Europe and at national level. In geriatrics, we use a lot of scales to assess elderly people, and these scales are international. All countries have translated them into their own language, but they're all the same. And this means that we can compare data in literature. In healthcare path organizations, we're also working a lot on this aspect, and in conferences as well. We're trying to find the best system. There's a European school in Switzerland, in Sion, in La Vallée, where lots of geriatricians go to talk about European practices. So in geriatrics, compared with other specialties, we've made an effort to work in the same way with the same tools. Now, it's true that if we visit some countries, we can see that at the end of the day, we don't have the same results. If we compare the geriatric wards in Italy, in Finland, in France, or Germany, we really don't have the same results in terms of practices. But we do assess people in the same way, and we do have the same target. We want to prevent dependence. We want to prevent a geriatric state. We all have the same objectives. So we share that, at least.
I think we should, this is an important point, that we understand what is the outcome of what we do. And I think at least today we have debated more how to control the data that we don't have when we are going to exchange it. I mean, the fact is that many European countries don't measure quality outcomes of different treatments for different prognoses. I think that is a core activity that should start. But as we know, there's a tradition of some resistance from a lot of parties, including the profession itself, to really publish and measure. I mean, quality should be measured every day in healthcare and published so we understand how we perform. Then we can start to compare and see where it's good or it's less good.
Madame.
Yes, I think that very specifically it's in this field that international groups like ours can provide something to local healthcare organizations, because per disorder, per speciality, we have the ability to compare what our different teams are doing, the protocols that work, for example, and progressively we can have intervention protocols and training as well for teams and have it all working properly. When it comes to locomotor diseases, this is something that we see a lot of in elderly people. In Italy and France, we have good quality centers dealing with these issues. We can see the extent to which, as you were saying, we're progressively aligning protocols, we're testing innovative devices, and we're making sure that we're making progress with quality. And this is what's just been said. We need measurement criteria, we need to measure efficacy, and we need to have teams that are speaking the same language and that exchange on a regular basis. This is something that I believe very much in, much more than in physical transport, the physical transport of patients across Europe. So at the end of the day, so we don't move them as much, cross-border medicine in Europe, well, it's simply the fact that we should be sharing skills, assess our skills, we should be moving skills and technology. We can talk about that as well. But is it not about changing local policies as well? In your European work, isn't it something that you can use to move the lines back? Yes, that's also why we're so happy that the members, almost all of the members, have adopted national plans for rare diseases. France is already at its third national plan. It's created specific sectors or units. So it's a model to be followed. But there are still problems, especially when it comes to rare diseases. When we talk about creating evidence or creating documentation, there's this desire to have proof, to have evidence that can actually reflect a desire to delay access to new medication. And that, in my opinion, means that it would be good to have closer cooperation and to make sure it's improved, this cooperation. This is what we've just heard about in the previous session. There is a need for patients to access new treatments quicker. So a study was carried out to know what patients' expectations were when they move around for treatment. And the first explanation, over 80% of people said, was to have something for a rare disease. So people with a rare disease are ready to move around. So how do you help them? What about their financing? Can you find them a financial solution for these patients with rare diseases? No, not yet, but we've suggested that there be a system for monitoring new drugs when they are put on the market. And perhaps there needs to be more sharing among governments and the pharmaceutical industry, generally speaking. This is so that we have the right kind of scientific evidence that the treatment is efficacious. There's just been a publication that's come out on a new drug for gene-based therapy. So a degenerative disease of the retina. leading to blindness. So we studied 45 people in the trial. And of course, that's not enough to really establish without any doubt that the drug is good without any adverse effects. But patients need the drug. Otherwise, they're going to go blind. So let's come back to competency exchanges. Do you have a lot of exchanges between your 5 or 6 countries to try and, strengthen your skills collectively? For each population, wouldn't it be good to have access to top quality medicine? Do you have an organization for exchanging ideas, for sharing training? How is it all operated?
And that's what we mean by moving the knowledge rather than the patients. Especially between France and the Nordics, there's been an intensive exchange during the last 5-6 years. And I think that has, at least to some extent, impacted the development of more outpatient activity in the whole French market and also shorter treatment times. And just to give one perspective there, when we started to address the issue of how long do you really need to stay in a hospital when you change your hip or a knee, I think the CAPI average was 8.5 days and the French average was about 10 days. Then we started to exchange experience between our markets, and today the CAPI average in France has gone from 8.5 to 3.5, and I think the French market has gone from 10 to 6 or something like that. But the very good news there is that the French doctors took it further. So they started task. We told them make it in 4 days, and they did. Then they asked, why does it need to take 4 days? So actually we make about 10,000 of these type of operations every year in France. 1,000 of those are made as day surgery with better results than the ones that are made over 3, 4, 5, 6 days. So I mean, there is a lot of power in exchanging knowledge, and I think some of it takes that you physically meet and maybe operate together and go to see each other. But more and more you can also use telemedicine, obviously, to exchange knowledge.
Et Madame Boissard, pareil, un gros dynamisme d'échange?
So is it the same? Do you have a lot of dynamic exchanges of knowledge? Well, for a group like Corian, yes. Outpatient medicine, treatments, day stays. Well, we've doubled our activity in terms of outpatient treatments, which is what Cetelia did before us. It's the same for this. We've done this for the same kind of infection, and then we're doing a lot of research as well. And you know the Corian Foundation. We select people with the scientific committee, bringing together the different medical heads of different countries. The research fields that we focus on are very specific. And then, of course, there's training with an internal academy system that makes it possible to stabilize the protocols and roll these out across the 4 countries. So, yes, it's through the healthcare professionals, and not just through the doctors, the community of healthcare professionals, the paramedical professionals. It's through everybody that we can really use the best of what we have in terms of medical offers. Does that also mean that you're going to be using more technology? You're going to be the president of the French Federation in the future, the French Society for Telemedicine. So what about these new technologies then? Telemedicine, so patients will not have to move around, but you will be able to go towards the patient. So there's a modification of the healthcare paradigm in that case. Yes, I think that telemedicine is going to move beyond the borders. It's going to bring down those barriers. Then we'll just have to rise to a number of other challenges, reimbursement, etc. And there are other challenges, the organization of medical facilities. I think telemedicine has a future. We're not going to get patients to travel, but get expert skills to travel. Are there examples that work, or are we still at project level? We're still at project level. There are a few examples, but outside of Europe and with Africa, with Asia, but not between European countries. In your groups, are you involved in telemedicine? Telemedicine is going to be integrated in European networks, and that will be for the future. I have no doubt that we will be able to make progress down this path. From time to time, and listening to the discussions this morning, this has confirmed my thought. We've been talking about a Europe for health, but we've got this Europe that's focused on fear. You know, we are experiencing passionate times. There are possibilities and technologies, there's scientific progress. We've talked about gene-based treatment. We need to make the most of all of these discoveries. We need to not be afraid and to cultivate optimism in health. Talking about fears, in the report, the European report drawn up, one of the fears and one of the obstacles that encourages the mover skills was the transmission of nosocomial infections. This was one of the major obstacles. So between establishments, and this is something that's blocking the fluidity of the system. The media have talked about this subject. I don't really have an answer to that question, but it would be interesting to use telemedicine in that case to fight against nosocomial infections. For telemedicine, then, in the French society, we're also working on reference systems. We're trying to create a reference system for expertise and training that would be in line with what we have in France. What we want is that this reference system be a European reference system. We want to kind of make sure that what we ask doctors and nurses to do might be the same. When I talk about telemedicine with doctors or healthcare professionals, we're very high up with respect to what they know, what people know, what even my parents know. When you go to when you go to a retirement home, you know, we're far above what people can actually do. Now, let's come back to the notion of tourism, because this comes back to a discussion that we had this morning on prevention. In this health tourism, this medical tourism, there are many, many aspects in the report, and it's a very dense report. One of Europe's ideas is to look at the use of spas, which is a key element of prevention. And, you know, you've got there are many spas, and they often take on our patients after an operation. Now, this kind of tourism, this spa tourism, is it something that you think about? Do you think it's going to be a way to move forward, or is it just you know, a thing kind of on the periphery? Who would like to react to that? As far as I'm concerned, some areas, some geographic areas, but this has been the case for many, many years, for centuries, are better for treatment than others, especially after a heavy-going infection or operation. You know, the whole south of Europe, for example, has lots of spas, and there's more sun, the climate is more clement, and there are places where people heal better than elsewhere. So I think that offer, which is a medical offer, it helps to accelerate healing and to provide a better benefit in terms of the treatment of the patient. I think that we haven't developed it far enough yet because the financing systems are very local. So there are niche areas. I'm sorry to talk in this way. There are some very serious infections where there are very few specialized teams, whereas it's better for these teams to move around. There are niches for this kind of rehabilitation, making rehabilitation better and more comfortable. I think it's good to develop this in the south of France, in Italy, in the right kind of climate. But I don't think that this will be the dominant offer for any kind of patient. We've got 2 minutes left, so things have gone very quickly. You have 30 seconds each to conclude. Or tell us about a wish, maybe. Tomorrow we've got elections. What wish would you like to express to help our healthcare system and to be more transnational? In 20 seconds. Well, first of all, I would like us not to get rid of lifts, please. Let's keep lifts. So that's probably linked to a certain law, I believe. And also, I would like that we integrate in the new health budget social aspects. I think it's good to have a good relationship between health and social aspects, but we've also got to take into account that there are countries, member countries, that are doing more cooperation and integration at European level, and there are others that are opposed to it. And then for rare diseases, we've got to have a committee of experts working on those. In 50 seconds.
To have quality measurements of important diseases and the outcome of the diseases, number one, because that makes it possible to compare and improve. Number two, freedom of choice for patients. We have it in France, but not in all European countries. Number three, freedom of providing healthcare dependent you live up to the regulations. Finally, I have to say that with the aging population in Europe, I think the hotel industry should continue to take care of the spas, and we have to take the money that the government might have left to treat a lot of elderly people.
Oui. So,
Thank you. Moi, une mesure
One measure, we want 6 months or 1 year of studies abroad for all medical students. And a measure, very quickly a measure, so bring down barriers, have cross-border telemedicine, and look at prevention of dependence rather than life expectancy. Thank you very much.